Hi, folks. It is 10:31, so we will get started. I know folks are still trickling in. I feel like it took me 15 minutes just to get out of the room and make it here because there are so many of us here today, which is wonderful. But we'll get started. And this is the first session of CAH 25, and I think it's going to be a pretty great one. My name is Chloe Halpenny. My pronouns are she or they, and I am a board member with CAH, as well as a couple other roles and titles that are far less important here. I'm nervous, even though I'm not even presenting, but you don't have to hear me speak for long. I'm just going to kick things off, and we'll turn it over to three amazing presentations to start off the session. Okay, so to start off, we'd like to begin by acknowledging that the 2025 National Conference on Ending Homelessness is taking place on unceded Indigenous lands. The Kanien'kehá:ka Nation is recognized as the custodians of the lands and waters on which we gather today. Tiohtià:ke, or Montreal, is historically known as a gathering place for many First Nations. Today, it is home to a diverse population of Indigenous and other peoples. We respect the continued connections with the past, present, and future in our ongoing relationships with Indigenous and other peoples from coast to coast to coast. And do just want to give a shout out and so much gratitude to the amazing opening plenary and all of the artists and elders who contributed so much and really, really started off, I think, the conference in a great way. So grateful for those folks as well. The room is, or does appear to be, equipped with simultaneous translation. So if you would like that or would benefit from that and don't have a headset, you can collect one from the level 2 or level 5 foyer. And feel free to use the headset to participate if that's helpful for you. And I think that's all I have to say. So without further ado, I will introduce our first presentation and first speakers. To start, we will be hearing from Christine Byrne and Sherry Froud from End Homelessness St. John's. And that's it. Take it away.
Good morning. Can everybody hear me? Okay, so End Homelessness St. John's. End Homeless St. John's Housing Outreach Support Team. I'm Christine Byrne, so I'm the Housing Outreach Lead, and this is Sherry Froud. She's one of our Housing Outreach support workers. So End Homelessness St. John's actually began in April 1st, 2022. After COVID, there was recognition that there was a lot of gaps. A lot of individuals who are in nonprofit shelters, profit shelters, and they weren't getting their proper supports. The profit shelters, actually, we noticed that they don't have staff, they don't have the support that they need for finding housing or for any medical needs. So that's how outreach began. And we collaborated with NL Health Services. And the reason why is we're in community and we're meeting the needs for people who have the medical issues and also are, of course, looking for housing, which we know there's a crisis for housing. So a lot of people were overlooked. So when outreach then became available, we were able to actually get out there, get into the shelters and provide support for the housing piece and also with the harm reduction team. Should I show you? Sorry, we're amateurs. Need the teams. Sorry, I got one ahead. Taxes. All right. What are we at? All right, so the outreach team, this is a picture of us. So basically, like I said, when we go into community, we do have a mobile van. And the mobile van actually is where we provide our support in community. With, like I said, is our group, which is we have one outreach manager, one team lead, 3 outreach workers, and on the harm reduction team through NL Health Services, we have 2 nurse practitioners, 6 psychiatric nurses, 1 pharmacist, 1 occupational therapist, 1 social worker, addictions counselor, clerical support, and 1 peer support worker. So we collaborate, we go into, like I said, we go to shelters, we visit various areas in community. We also go to like different, it could be tenting sites, people living on the streets, and we try and target the hot spots of where we know people are actually homeless. Okay. All right, so the importance of working together. Am I doing that? Okay. Focusing on the connection between housing and health through outreach and drop-in services. It works really well because it gives the opportunity for individuals to come to us if they need medical and housing or either or. We provide that service because we have a clinic. We have 2 clinics actually. That is a drop-in service, which we can provide outreach services from there, or they can go and see the harm reduction team if medical is needed. It could be mental health, it could be anything at all. A lot of individuals who are homeless, of course, don't have medications. They don't have no way of getting referrals done for example, if they need psychiatric or whatever. This gives them an opportunity to come to us, but we also, like I said, we provide the service of going on the van. We have a nurse with us most times, or it could be OT, and we will go to where they are, meet them where they are in the community to actually give them whatever kind of support we can. By getting them in our system too, like through coordinated access, we can actually keep them in our system and we can follow them to see if they get housed, if they are in community and need a housing access worker. With our partner agencies, they have certain individuals that are actually housing access workers. So when they go in our system, basically they will then be connected to a housing access worker. So it's really strengthening outcomes through collaboration between housing and health. Because, like I said, it's hard for an individual who's homeless or out in community to, say, get a family doctor or to reach out for that help. But if we're in community, we build a relationship, they come to us, they know the nurses, they know us, and they know that we're willing to basically provide whatever support we can. If not, we'll try and get the support they need, even if it's just getting a drug card. A lot of people don't have drug cards because they don't have an address. So, we provide other options or redirect them to how they can get that info. Click. You should be clicking. No, sorry. All right, so how do we address the gaps? Like I said, we're providing support across multiple locations. Healthcare and essential services, it's like I said, it's a barrier for people. And our presence in shelters, clinics, community, and spaces, it ensures that the vulnerable population can receive that ongoing support which is needed. Through our various partners too, with healthcare providers, community and government agencies, we create coordinated approach and it connects the individual to the necessary resources. And that is a big gap in community and everywhere, I think, because people don't know that support is available, and it's just a matter of connecting with individuals so that they can be redirected. Okay, so where we visit, not many places we don't. For-profit private shelters, we call them private shelters, but for-profit, not-for-profit shelters. Community agencies, various community sites, a mobile van, which could be, like I said, different hotspots where we know individuals are probably frequenting, where they're probably hanging as a group, and we know many of them are homeless. So that would be like unsheltered locations. If we get a call from City St. John's, we have individuals who are reporting they see a tent or somebody sleeping on a bench. We will prioritize to get out there to connect with them, get them in our system, try and get them connected with the supports that they need at the time. NL Health Services Harm Reduction Clinic. Like I said, we work out of a clinic with the nurses, but we also have a downtown collaborative clinic, which is where they're 3 days a week. So people in the community are aware that they can go to either one of those and they can connect with us or with the harm reduction team. So our role, so application support and system navigation. So weekly, like I said, we have a schedule that we do on a weekly basis for the different shelters in our community and unsheltered locations. We support clients in accessing housing resources, funding, and other essential programs. Because we also see a lot of people who are applying for support, they don't have an address, so they got no money coming in. When they got an address, then it's basically for us to assist them in, say, if they need something faxed off, or they need the application filled out, or they need an MCP card because they can't get health care, birth certificates. We do income tax. We try and fill all the gaps that we can to make sure that they have everything in place to try and get them into housing. So basically, when they get connected with a housing access worker, then they would have main A, B, and C, and D actually in place. I'll lose my voice. Okay. So we do deliver support services across a diverse range of locations. Oh, sorry. Including, no.
Okay.
Sorry. Here we go. I know how to do backwards. Okay. So we have 15 shelters actually that we visit on a regular basis, 3 community agencies, 3 community outreach locations on our mobile outreach van. That don't include any calls, like I said, that we get that we know somebody's rough sleeping, or somebody could be, I don't know, looking for assistance in the moment. We try and get out there with a nurse with us, could be mental health. Then we can find out when we get there that they may need, say, housing. Then we'll fill out all our intake, consent, and our housing application, anything that we can get in the moment while we have them there in paper readiness, basically. All right, so we're going to do, Sherry's going to do a case study there now.
Oh my. Hi everyone. We want to share a short case study that really reminds us of what this work is all about. Relationship building, trust, and patience. This isn't about quick results or big breakthroughs, but about small, consistent efforts that led to real change over time. This is about John, who had been chronically homeless for several years. He is a good example of how trauma-informed practice and collaborative efforts with community partners, Newfoundland Labrador Housing Corporation, NL Health Services, and Homelessness St. John's, and simple human connection can make an enormous difference. John is 63 years of age. He experienced over 4 years of chronic homelessness, with the primary goal of reuniting with a family member. Early, consistent engagement with outreach teams from Homelessness St. John's and NL Health Services was challenging, as it took over a year of consistent, low-pressure contact to build trust and a meaningful relationship. During this time, staff focused on being present and reliable, meeting immediate needs, checking in regularly, and maintaining connection. This steady support helped John feel safe and valued, laying the foundation for progress. An interaction that we had with him highlighted this. We dropped down to where John was rough sleeping, and he was asking about paperwork that we had completed the week before. During this conversation, he mentioned that his foot had been bothering him for quite a while. One of the harm reduction nurses took a look and there was a large wound on his foot. So we got him to come to the mobile clinic van, be assessed, the wound dressed and cleaned, and we gave him some clean socks and sneakers and told him we'd be back tomorrow with some more dressing supplies. He was really appreciative. This is the first time that he ever asked for help with the health team. It was huge. John had several temporary housing experiences, including a transitional supportive placement and shared accommodations, both of which were short-lived due to distance from supports and safety concerns for visitors. Throughout this, his housing stability worker remained a consistent presence, helping John navigate setbacks and explore housing options. Beyond housing, we work in close partnership with NL Health Services to provide wraparound supports and address the social and structural factors that impact health and stability. Oh my God, I need water. Issues such as mental health, substance use, and chronic illness can make it difficult to maintain housing. By surrounding John with coordinated supports, we are able to promote both housing stability and overall well-being. The outcomes and impacts of working collaboratively with NL Health Services have proven to have positive long-term outcomes, such as higher tenancy retention, better health outcomes, fewer hospitalizations, better management of chronic illness. Oh my God, I need some water. A reduction of crisis events, fewer interactions with the criminal justice system, which resulted in cost savings over time. Costs in health, social, and justice sectors often drop off when homelessness is reduced. Oh, thank you, Christine. Thanks. Sorry. Most importantly, improved quality of life and stability. People report feeling better and therefore more stable in their health and housing outcomes. Finally, a suitable living arrangement was secured for John, which has been successfully maintained for over a year. John has since reunited with his family, and they now live with him. And they no longer require ongoing support from his housing worker. This illustrates the power of patience, consistency, and trust in helping someone transition out of chronic homelessness, showing that relationships matter just as much as paperwork or placements in achieving meaningful, lasting outcomes. What we really took from this experience is that progress can appear slow from the outside, but for people that we work with, those small moments of consistency and respect can be life-changing. Our first goal is building trust. It reminded us that our job isn't about helping someone get housed. It's about helping them rebuild trust, confidence, and connection.
So that was just one of our success stories, right? We have, for probably 10 that are not successful, that one is very powerful for us. And I already did our support services. So this is our annual stats. Now, this is only the information that of individuals that we actually engage with, had an interaction with. There's many, many more people out there. But you can see by the stats, like client interactions would be any interaction. Could be them calling our outreach line. It could be just somebody popping in the clinic to see us. Somebody coming to the van. Applications completed, it could be a number of applications, income support, NL housing, our intake and consent. We also do like City St. John's applications if they requested, MCPs, income tax.
Everything.
Yeah, just about everything. Drop-in support days, so that would be at both our clinics. We've seen 340 people in that time frame. Tax returns filed was a whopping 480 last year compared to the year before. So the word gets out and a lot of individuals are coming during tax season, which is a big thing for individuals. If they don't have their taxes done, they can't get a Canadian housing subsidy through NL Housing. So they can't avail of a subsidy. So our thing is, first thing we say, okay, you got your taxes done. If not, we'll do them right on the spot for them. Secondary support was 52. So that is our partners in community. They have staff actually going, visiting individuals. Could be people that they're getting on their caseload, could be people who they have housed, and they just need a secondary to go and do a visit as such. Our mobile outreach unsheltered visit, so that is actually, could be, when we're on the van or we're in community. Unsheltered, like I said, it could be tenting. It could be we get reports somebody sleeping on a bench. It could be just a call somebody we're looking for a long while, probably to update their intake. And we'll go out and we'll update their information in our coordinated access by name list. New individuals identified as experiencing homelessness was 150. So you got to look at, that's only the ones that are identified. There are so many more out there that when we're in community, we're trying to find them, get the intakes and consent done to get them in our system so that we can actually keep them on the radar, try and get them connected so that we can, eventually get them housed or get whatever supports they need. It could be, like I said, medical, or it could be just something to do with housing. And that's all that we have. So, I'm sorry. And this is our contact information if anybody wants to reach out to get some information. And I do apologize. We're rookies at this, so thank you very much.
Thank you.
Thank you. Thank you so much, Christine and Sherry. And yeah, no need to apologize. Not rookies at all. That was great. And speaking of rookies, I realized what I forgot in the introduction, which was to introduce the title of the session. If you haven't already figured it out, the session you're in is Collaborative Approaches for Integrated Service Delivery, Housing, Health, and Culturally Relevant Services. And you guys did a great job at kicking us off. So thank you so much, Christine and Sherry. Okay, just a note, we will do Q&A at the end after all three sessions. So if you've got questions, keep them with you, sit tight, we will get there. But I will now introduce, let's see how, okay, I'm gonna change the slides and this is gonna be fine. Okay, I think we'll now introduce the folks from Thunder Bay, if you guys are ready. We've got Annika Gregg from the Thunder Bay Indigenous Friendship Center, Bonnie Krisawati from the Lakehead Social Planning Council, and Holly Gauvin from Elevate NWO to share a little bit more about the work that they've been doing in their area. All right.
Hi, everyone. Can you hear me okay? Yeah? Okay. So I'm Annika Gregg, and I'm the Manager of Housing Operations at the Thunder Bay Indigenous Friendship Center. Bonnie and Holly, do you want to introduce yourselves? Do you want to do it when you come up?
Yeah.
Yeah? Okay. Alrighty. And we are presenting today on encampment solutions in Thunder Bay. I do want to say thank you to Chloe for providing a land acknowledgement at the beginning of this session and acknowledging where we're gathering today. Before we go any further in the presentation, I also want to acknowledge where Bonnie, Holly, and I live and where our work takes place as well. So the land where we're coming from is the traditional land of the Anishinaabe people and is where they and many other peoples have gathered for time immemorial. This sacred place, originally known as Anemki-Wekwadong, is the treaty territory of Fort William First Nation, signatory to the Robinson Superior Treaty of 1850. This place is where, with the contributions of Métis people in this area, a small, thriving community formed into what has now become Thunder Bay, Ontario. In giving this presentation, I also want to situate myself in this work, acknowledging that I'm a settler on these lands, and I recognize that I hold a great amount of privilege because of this. I'm grateful to work for an Indigenous-led organization and take direction from Indigenous leadership in the role that I'm in. Miigwech. I'm going to provide a quick overview of what our presentation will be going over today. So to begin, we'll be providing a brief context of Thunder Bay. We'll discuss the collective impact and collaboration that occurs in our community, co-funding between funding partners, and a brief history of some of our co-funded initiatives, going a little bit more specifically into the 23-24 Winter Top-Up Funding Initiative. We're then going to hear directly from Holly with Elevate NWO, who led this initiative, and Holly will also speak to advocacy and policy change. We'll then close out the presentation by looking at some data and providing some recommendations for you to take back to your communities. After this presentation, we're hopeful that participants will be able to understand the dynamics of encampments in Thunder Bay, identify how collaboration among organizations, governments, funders, community groups, and advocates fosters solution-driven initiatives. We're hoping that folks will realize how collective impact with Indigenous partners, stakeholders, people with lived expertise, and community can lead to effective and actionable solutions for homelessness. And we're hoping that you'll be able to take some things back and apply these lessons in your own communities. So I'm going to give a little bit of a context of Thunder Bay. Thunder Bay is located on the northwestern shores of Lake Superior, about a 16-hour drive from Toronto, Ontario, and about a 7-hour drive to Winnipeg, Manitoba, to give some perspective on where we're located geographically. Thunder Bay is a beautiful place to live if you love the outdoors. We're surrounded by many lakes, forests, and mountains, including Anemkiwaju, Thunder Mountain, and Nanabiju, the sleeping giant, which is seen on the screen here. Despite how remote it can sometimes feel in Thunder Bay, our community actually serves as an urban hub in northwestern Ontario for many remote, far north First Nation communities in the Treaty 3, Treaty 9, and Robinson Superior Treaty areas, where access to medical, education, mental health, and other vital services are incredibly limited. Indigenous individuals and families from northern communities relocate to Thunder Bay for various reasons, and Thunder Bay is recognized by the government as an urban center with a significant population of Indigenous folks living off reserve. According to the 2021 Census of Population conducted by Stats Canada, the city of Thunder Bay has a population of just over 100,000 people, give or take. And census data also shows that of that number, close to 17,000 people identify as Indigenous, representing 14% of the total population. But it really should be noted that it's believed Indigenous people in Thunder Bay are significantly undercounted in census data, and a more accurate estimate is around 25% or more. In contrast, according to the Thunder Bay 2024 point in time count data, 78% of people experiencing homelessness in Thunder Bay identify as Indigenous. As with many communities across Canada, the number of individuals sleeping rough outdoors has significantly increased over the past few years. The 2024 point in time count showed that of the 557 people surveyed, 222 people told us that they would be staying in an encampment or outdoors in a public space. Of those 222 people, 220 identified as Indigenous. This is the reality of Indigenous homelessness in Thunder Bay, and I want you to keep this context in mind as we continue with the presentation.
Okay, I'm going to talk a little bit about collective impact. I hope you have all heard about collective impact. If you haven't, Google it when you're finished this session and read all about it. But I'll give you a little bit of information. So we could not have done any elimination of encampments or even part of that without collective impact. It's always been a collaborative effort in Thunder Bay with organizations, community entities, governments, funders, and advocates working collectively together. And we know that one organization or one government cannot do it, or it would have been done by now. And in Thunder Bay, as we move forward, we are becoming more collaborative in our efforts. There's a reason we're taught at a very young age to cooperate with others. But as we get older and we get out into the workforce, we realize that bureaucracy, rules, regulations, and policies, collaboration is not as easy. So we really have to work at it. It takes work, it takes effort. So just keep that in mind. The collaboration in Thunder Bay took years and years, but it was absolutely worth it. So in Thunder Bay, there are two major funders for homelessness initiatives. There's the federal government and the provincial government. I'm still on collective impact, yeah, sorry. So the provincial funders come from an entity that serves the entire district of Thunder Bay. We're lucky in the sense that the office is situated in Thunder Bay and we're the biggest location. So Thunder Bay actually gets most of the pot of that money. The municipality is examining spending some money, but in the past they haven't been involved in homelessness initiatives. The federal funding, of course, comes through HICC, and the provincial funding goes to an entity called the District of Thunder Bay Social Services Administration Board, and that's who runs the provincial funding. And we worked together, the Indigenous community entity, the designated community entity, and the province to come up with ways to do some co-funding. And that really started with COVID-19 because we were all given all kinds of money. I mean, the Indigenous CE was given millions, the designated CE, we were given millions, and the province had millions of dollars too. So we thought it was best to get together, talk about it, and figure out how we wanted to fund initiatives. One of the most important things was that we didn't want to leave any gaps or barriers. And we didn't want to double fund projects because we wanted our dollars to spread as much as they could. And we actually, even to this day, still meet on a regular basis to talk about co-funding. So that is one of the fabulous things that came out of that. We collaborated with fire, EMS, police, and especially other organizations like Elevate, who were so imperative in helping out with isolation shelters, overflow shelters. And because Elevate is a health organization, and I'll let Holly speak to more of that, we felt really fortunate that we had that expertise. And so not only were people just getting shelter and food, but they were getting immunizations and they were getting testing and masks and sanitizer. And we knew how to safely space people and where to put beds, et cetera. One of the barriers we did have was that we really were directed by the federal government to find a location in the city that we could use this millions of dollars for and fix it up so that we would have a place in the future to be able to house people that were experiencing homelessness. Unfortunately, the municipality was not as cooperative and did not give up a community center. So we actually spent that millions and millions of dollars on hotel rooms. $10 million about. Really unfortunate because what happened was, as you can imagine, hotels were, there was some damage done. And there's actually only one hotel in Thunder Bay now that we can utilize to house people that are experiencing homelessness in the winter. Extremely unfortunate because that, of course, increases the amount of people that are sleeping outside in the winter. And if you could remember from the map, we're on the northern shore of Lake Superior, and our winters are pretty brutal. We can get 40 below temps. But again, having this health organization help out with all of these small initiatives we had within the one big endeavor was actually crucial. And Elevate was, a small organization, received about $75,000 from our province to help with encampment solutions. And then when Annika and I were offered $1 million each in the winter of 23-24, our first order of business was to speak to each other to figure out what should we do with the money. And we knew it needed to go to encampment supports. I mean, there were people that were dying outside, overdosing outside, and there were fires outside, people trying to keep warm. So we contacted Holly and we said, can your organization, manage encampment support? And they did because there was no other choice. There literally was not any other organization in the city that had the capacity to be able to do that. It was this small health organization, this nonprofit. Winter top up, perfect. So, like I say, the winter top up funding was the ingredient we needed to be able to almost eliminate encampments in winter 23-24. And we thought it was interesting after we did this that nobody commented that there were no tents set up in areas that were commonly lots of tents set up, but nobody really noticed. And to this day, it still kind of boggles our minds that nobody saw them actually almost disappear that winter. But again, when you see more encampments, that's when people really notice. And we presented this, of course, at a city council meeting and let them know what was happening. They talked about it on the radio, so people kind of knew. But I mean, if you work in the field, not everybody in the community knows exactly what's happening behind the scenes, right? But again, that winter top up, the CEs really, relied on Elevate, the health organization, to be able to come up with some solutions and house people and offer the supports and services they needed. And I think Holly's next.
So I'm Holly Govan, and I'm going to do three things, or try to do three things. I'm going to make you laugh, I'm probably going to make you cry, and I'm definitely going to swear a lot. So I have the proud honor of being the executive director at Elevate NWO, this little organization that during COVID was called a fringe organization. I love that. And we provide HIV, Hep C, and harm reduction treatment to people in Thunder Bay and in Northwestern Ontario. And so harm reduction, I always like to say this in every presentation, harm reduction is not the enemy of abstinence, but that rigid thinking around abstinence as the only path is the enemy of our people, and our people are dying. So fuck it. Everybody be a harm reduction worker. There, now I've sworn. I got 2 out of 3. I only have 1 more to go, people. I love this. All right. One of the reasons why this work is so deeply meaningful to me and why it is a hill I will die on, I have lost sleep, I have lost health, and I have lost reputation in this, is because in 2020, my son and I were homeless. I was in my 3rd year of university. My son needed emergency dental surgery, and it wiped us out, completely wiped us out. There was no social safety net, but we had to survive. So we ended up going into a shelter, but this was at a time when there was a thing called women's residence, where homeless women and their children could safely stay. That no longer exists in my municipality. They gave that up. And so we don't have the options that many other communities have. And so I consider myself blessed because within 4 months, I was able to get out of it. Now, I want you to think back to the number of people on your caseload who have been there for 6 months. Now, hands up, how many have people on their list that have been homeless for a year? How about 2 years, 3 years, and more? Yeah, that's most of the people in this room right now. I almost lost everything. I almost lost my whole academic career. I almost lost my child. I almost lost my damn mind. And here I was, a white, privileged woman in 3rd year university who really just needed to sail through a couple of really bad months. And it was almost my undoing. It's pretty amazing. So they've talked a little bit about the setting, Thunder Bay, the sprawling metropolis of Thunder Bay. So some of the things that they don't say, I'm not an ambassador for the city. So I will say Elevate is a cautionary tale. Frankly, our community is really broken. And there's too many people still running around pretending it's not. So we are leading in overdose fatalities. We were dubbed by the federal government as a racist hotspot. Yeah, try to keep your head up at conferences when that's what you're known as, right? So when Annika's talking about the number of Indigenous people out in the homeless encampments, what she's talking about is systemic racism that has continued to put Indigenous people out on the streets and keep them there. I have one gentleman, one of our success stories, thankfully, who was homeless for 15 years. 15 consecutive years. And so sometimes he went to shelters and sometimes he slept on the streets and sometimes he was able to be taken in by family and friends. But 15 years of never having a home. 15 years of never being able to get stable. And he isn't the rare one. So what started our crazy ass journey, we were just this really happy-go-lucky organization. We're kind of a niche organization doing HIV and Hep C treatment until one day in 2020, some asshat decided that they were going to drive a truck through the tent of one of our people. That person had escaped that tent seconds before the truck had hit them. One of our city council members at the time, thankfully not on the city council anymore, went on and said, "Oh, well, I really hope it was just an accident." The pathway that this person had to drive was no accident. The devastation that created was ridiculous. It so angered and enraged my team, my board, my community, that we drove up in our cars and said, "Get in." As a group of strangers, get into the car, I'm taking you to the hotel. Imagine being so desperate that you hop into the car of a stranger who wants to take you to a hotel. Imagine how desperate, how cold, how hungry you have to be. So they did. And we took them to the hotel. And then we went back to the Homeless and Housing Coalition meeting and said, okay, well, we've got a week's worth of funding to keep these people housed. We want you all to go back to your budgets and find us some money. Otherwise, all these people are back out on the streets. That was the year that we had only 30 people known to us who were actually sleeping rough in our community. That was the year that 99% of those 30 people were Indigenous, meaning one participant was not Indigenous. So when we talk about racialized homelessness, we really need to call it what it is, and that's white supremacy. It's the centering of whiteness, and that is the biggest problem that is happening in our housing systems today. And I hold myself up in that as well, because we're all colonized people, right? And we all center whiteness because that's what we've been conditioned to do. And that's what white supremacy is. Those dorks in the hats, those are extremists. Those are just wingnuts, right? But white supremacy is the centering of whiteness. It's setting the standard that says the right way of living is the white way of living. How many housing programs have a limit of how long you can have a visitor? Right? That's a very white way of thinking. I grew up, I moved out of the house. My parents come to visit me. They'll visit me for a week to 10 days, maybe 2 weeks, which really drives my husband crazy. But maybe 2 weeks they stay. So that's the standard that you're usually allowed to have a visitor, right? It's maybe 2 weeks. In Indigenous culture, that is not the way of being, right? That is not the way of being. We have people who come into our community year after year after year because of fires and floods and other community disasters. They're not in their hotel rooms. They're literally out in the hallways because they want to be together, because it was safe to be together, because that's how they understand family. That's how they understand community. And yet in housing systems, they wind up becoming homeless because of that very value. We say white values are the right values. And as long as our programs, as long as our services continue to send that message, we're going to continue to see this increase in homeless, and it's going to continue to be racialized people that will be overrepresented in the numbers. So please, please, please ask yourself, my policies, what is it that I am holding up as a white standard, as opposed to the work that should be done, which is understanding where people are coming from. And I think I've gone on many, many rabbit trails. So I didn't make you cry, but it did make you laugh. I cursed a fuck of a lot. And now I'm going to hand it back to my friends.
So I didn't get a chance to introduce myself, but I'm Bonnie Crisawati, and I've been managing the designated Reaching Home Funds as the community entity for about 11 years in Thunder Bay. And do you see why we fund Holly's organization? Because I can't say that, but Holly can. So we speak vicariously through Holly. But one thing I did want to talk about quickly is data, because Holly has been able to encourage us to get data from our point in time counts, from and other data collection systems, HIV testing, HCV, BBI, RNA, giving flu shots, 79 flu shots during our point in time count last time. So yeah, we had a nurse practitioner and a nurse available during the entire 24 point in time count on call, and we did utilize them. So being connected to a health organization when it comes to data, extremely important. We've also been able to highlight in our point in time count substance use, health data, drug consumption information around testing and using, and also issues around substance use as well. So just wanted to mention that quickly.
I feel, should we wrap it up? Okay, I will very, very quickly wrap us up with some recommendations. Oh, it's not coming up on here. Maybe that's the hook off the stage. But anyways, just to share some recommendations for this work. So we just wanted to share, it's really important to be patient in this work, but also to be impatient. Patient in building meaningful relationships with community partners, and patience with each other, but also in patience with the system, like Holly spoke about. We can't wait around for the system to change, and we often need to use our impatience to drive action and change. Abiding by the grandfather teachings of honesty and truth, being transparent and open with one another to build a foundation of mutual trust, not only among community partners, but with the community members we're supporting as well. Humility, which is another one of the 7 grandfather teachings, being willing to approach collaborative work with the recognition that you're not always the expert and acknowledging that there's always more to learn. It's crucial to take direction from individuals with lived and living expertise, Indigenous community members, and grassroots groups who have boots on the ground. It's important to have knowledge of homelessness in your community, particularly as funders, and to know what's going on in your community and who is doing the work. Because we knew of the work of Elevate and what they'd been doing with the encampment outreach, we knew that they would be the first organization to reach out to for the intervention that we were speaking about today. And something that Bonnie always says, this will be our wrap up, is just to simply pick up the phone. Because of our existing working relationships, the winter intervention and subsequent interventions have been coordinated quickly and easily with a few phone calls between each other. Relationship building can be complex, but it doesn't always have to be. And if you're wondering what your partners in your network are doing, just pick up the phone and let the conversation start somewhere. So, miigwech.
Okay, thank you so much, Bonnie, Annika, and Holly. I'm a terrible timekeeper because I really hate cutting people off when they're saying things that I really agree with and love. So thank you so much for that excellent presentation. And you're going to maybe have to fix the slides. Thank you so much. I will invite next our final presenters up on the stage. We've got Emily Jordan from the Sanguine Health Center, Laura Muhlenbeek from the Sanguine Health Center, and Jose de Lima from Thrive HIV Prevention and Support. And you will have slides hopefully soon as well. Excellent. Thank you so much. All right. Please welcome them to the stage.
Good morning. Okay, we're going to try it again. Good morning. Bonjour. My name is Jose de Lima. I use they, them pronouns, and I am the Cambridge site manager at Thrive HIV Prevention and Support, and I get to work alongside and supervise the Thrive Street Outreach team, as well as our drop-in center.
Good morning. My name is Laura Mullenbeek. My pronouns are she, her, and I'm the care facilitator with the Sanguine Health Centre on the Cambridge Outreach team. I've been in a number of roles at Sanguine over the last 3 years and in this position since August of 2023. My role on this team is primarily service navigation, social support, and case management.
Hi, everybody. My name's Emily Jordan. I'm a registered nurse. I've been a registered nurse for 8 years, working across various sectors of our healthcare system. Currently, I am the registered nurse and team lead of the Sanguine side of our Cambridge Outreach team. Oh, great. We just have some learning objectives for you guys today. So hopefully at the end of the presentation, the participants will be able to understand the different outreach roles and functions of the Cambridge Outreach Program, explain how integrating housing and healthcare increases engagement and with individuals experiencing homelessness, identify the key requirements and considerations necessary for incorporating nursing support in an outreach team, and understand the role that unaddressed physical and mental health needs play in supporting long-term housing stability.
All right, so the Frontline Cambridge team is composed of 3 outreach workers and a registered nurse. In addition to the drop-in site, the team connects with participants in community spaces and goes out on foot to encampments. While we provide support care and system navigation assistance to anyone who may be in need, our primary population and mandate encompasses those who are unhoused and living outside.
Okay, so the Cambridge Outreach team is comprised of 2 organizations. Sanguine Health Centre is one of them, and it's a not-for-profit community-based health agency with programs based out of the Waterloo region and the Guelph Wellington region. Sanguine was started in 2008 in response to community needs. Our organization's executive director, Dr. Chris Steingart, an infectious disease physician, recognized that there were many people in our community living with hepatitis C that didn't have access to treatment. Together with his wife, Michelle, Sanguine was formed and has become an important resource and support for people living in at-risk communities. Today at Sanguine Health Centre, we envision a future where housing status no longer dictates suffering and where everyone feels empowered to pursue proactive health for themselves. We strive towards this by offering expert and compassionate Hep C and primary care, alongside innovative programs that are rooted in harm reduction and aim to address our patients' diverse needs. Through education and outreach, we aim to raise awareness of harm reduction, combat stigma, and minimize the impact that marginalization has on vulnerable communities. We have a variety of programs and services, such as a primary care bus, that was on the last slide, community health vans, the WINS program, which stands for Working to Improve Neighborhood Safety, ESHRI program, which stands for Emergency Shelter Harm Reduction Integration Initiative, drug checking, safe supply, and our supportive housing and health initiative. Most importantly, across all of our programming, we have the privilege of working alongside our peer outreach workers. These dedicated individuals, members of the community with lived and/or living experience, play a vital role in ensuring that our work remains grounded in the voices and experiences of those with living or lived experience. I said that twice. It's very important. Their insight and engagement are the reason Sanguine remains deeply connected to and trusted by our communities.
So at Thrive, we work toward a future where new HIV, hepatitis C, and other sexually transmitted or blood-borne infection and diseases are rare in Waterloo region and Guelph Wellington. We've been at it since 1987, and over 30 years later, we still run support groups, provide HIV self-testing, we provide connections to PrEP clinics, and deliver harm reduction services. We have evolved over the decades, and especially since the COVID-19 pandemic, to offer targeted prevention and outreach through the African and Caribbean Strategy Program, the Women in HIV/AIDS Network, the MSM Sexual Health Program, the Youth Sexual Health Program, and our support and peer support worker programs. We have satellite sites in Guelph and in Cambridge, and we collaborate with incredible community partners who help us to bridge the gaps in prevention and care. And so we ask ourselves, why did Thrive and Sanguine decide to partner? And why did Thrive open a satellite site in Cambridge in 2020? Back when COVID-19 started, and we've heard this a couple of times already, we saw the need to change the way that we interact with our communities. We saw despair and a lack of resources that meant that we had to do things differently because no one was going to come to help us. We had to be the ones to craft the way forward. And so in 2023, the Region of Waterloo put out a proposal for the street outreach contract. Cambridge Housing Stability Street Outreach, which I used to work in, usually has been one agency with 2 street outreach workers, and that's how it's done. But then Thrive and Sanguine got involved and said, hey, we're gonna do something different this time. And so Thrive and Sanguine partnered. It's a team of 4, and we now have housing and healthcare outreach for the first time ever in Cambridge's history together as part of an integrated team. And thank you. So we submit the joint application. We now have 3 outreach workers and an outreach nurse. It's an integrated team, and the team speaks to the work that we started doing in 2020 with the drop-in site, which you will hear me talk about in a few minutes.
All right. So some services we provide. While the majority of our focus falls on housing and healthcare, we try to act as a one-stop shop for service navigation. This at times includes work on the peripherals of this focus, such as court support, being present at encampment evictions, access to veterinary care for pets, and at times when there's nothing tangible to offer, we show up to be a listening ear. The systems put in place for people to access affordable housing, trauma-informed and accessible medical care, addiction support, food and income support, and many other services is not an easy system to navigate. Shelter spaces are ever-changing, organizations experience funding cuts, and workers turnover. Even as the quote-unquote experts in system navigation, we are constantly learning and adapting to new circumstances and resources. This is a full-time job, and it is not a job that's easy to do when you're living in survival mode. With that, our goal is to offer appropriate support to the needs of each individual we work with. We offer food and supplies. Prior to the creation of this team, Thrive and Sanguine were already partnered on the Cambridge van using the original Cambridge community health van, the Dragon Wagon, as seen above. We drop off clothing, harm reduction, warming gear, food, hygiene at a few different spots in Cambridge, and we continue to provide this service using stops as an opportunity to follow up with case management and healthcare. To support folks in accessing healthcare, Emily is able to meet wherever patients are most comfortable being seen to provide on-the-spot nursing care and referrals. The outreach team provides social support and follow-up care by coordinating appointments. Sometimes that's as simple as a reminder the day before and a bus ticket, while others may need more direct support with an accompaniment. Our role in housing services generally starts with an application for our Community Housing Access Center, and then the next steps depend on each individual's needs. We use a person-centered and relationship-based approach in all of the work that we do, and this becomes particularly relevant in housing services, where knowing a client on a personal level impacts what services are best suited to them. For example, is this person a candidate for priority housing? Is there a way to increase income? Does this person have the skills to succeed in independent housing, or are we gearing our search towards supportive? We continue to provide regular follow-up with individuals to ensure that applications remain up to date, and then depending on the track to housing, our primary housing responsibilities may end once they're connected with a housing liaison from a partnering agency. And finally, both agencies are set up to provide harm reduction gear as needed. This includes supplies for safer substance use, safer sex, naloxone kits, and between the drop-in space, van service, and the trunks of all of our cars, we keep a pretty steady supply readily available and are prepared to provide education and resources on safest practices when requested.
Okay, so how to incorporate nursing care. Integrating nursing care into outreach enhances the team's ability to provide holistic, client-centered support. Nurses bring clinical expertise, health education, and system navigation skills that complement the harm reduction and housing work already being done. So how does one do this? I think it's important to define the role of the nurse. So outlining the nurse's role is essential to determine what services your team can offer to the community. The nurse's responsibilities may evolve over time based on community needs, available partnerships, and the composition of your core team. For organizations seeking to hire a nurse for outreach, it's important to understand the scope of practice for different nursing designations to ensure the best fit for your program. This information can be found on the College of Nurses of Ontario website for people in Ontario, sorry. But each province has a regulating website. If your team, the nurse on your team does not have access to a prescriber, the nurse's role may focus on basic wound care, harm reduction education, and system navigation supports to connect clients with appropriate health services. If your team does have access to a prescriber, then they are able to offer this and much more, such as medication support, vaccinations, diagnostic testing, and more comprehensive clinical care. This includes assessment and management of acute and chronic conditions, and under appropriate delegation or collaboration agreements. I am fortunate to work alongside nurse practitioner Erica Laban and physician Dr. Maria Matsuda. Having these two providers as resources allows me to provide a variety of services to the people in our community. My role on the team has become harm reduction and acute care focused, so I'm able to go out and assess people in the community and call the providers that I have access to if I need a prescription, such as antibiotics. I am also able to do blood work in the community, which makes it very low barrier for a lot of our participants. Another important point is ongoing education. So if there's any nurses in the room, you will recognize the three words up there: knowledge, skill, and judgment. This is a cornerstone phrase of nursing practice. It's a guiding framework that nurses reflect on to ensure every action they take is performed safely, competently, and within their scope. It asks us to pause and consider, do I have the knowledge? So do I understand the theory, the rationale, and the evidence behind what I'm about to do? Do I have the skill? Have I been trained, practiced, and demonstrated competence in this task? And finally, do I have the judgment? Do I have the resources, support, and environment necessary to perform this activity safely and in the best interest of the client? So what I think that really comes down to is just recognizing both your abilities and your limitations. It's completely okay to not know everything. You're not going to know everything, or to encounter situations beyond your scope of expertise. What's most important is knowing when to seek support and how to connect clients to the right resources. This is where strong partnerships with other community agencies become essential. By collaborating with local health providers, outreach programs, and social services, teams can bridge gaps in care, ensure clients receive the right support at the right time, and foster a network of shared knowledge and trust. Which leads me to my next point, which is building community partners. So working with other healthcare agencies in the community is essential to ensure that as many people as possible have access to comprehensive and coordinated medical care. Building strong relationships with local organizations that provide health and social services helps create a network of support for individuals with complex needs. I urge you all to investigate what organizations in your community offer these services and establish open lines of communication with them. Collaboration can take many forms, such as sharing resources, cross-referrals, or participating in joint outreach initiatives. It is also valuable to be physically present in the same spaces as other community partners. So drop-ins, meal programs, shelters, outreach events to foster trust and build authentic connection face-to-face. These interactions not only strengthen partnerships, but also increase visibility and accessibility for those who may be hesitant to seek care. Consistent engagement and collaboration ensure that individuals receive seamless, person-centered support across the continuum of care.
So between our street outreach and drop-in programs, we have about 17,000 to 20,000 interactions every single fiscal year. Our drop-in opened in 2020, and then you ask, how do you get to that number, right? We see over 700 unique individuals in the city of Cambridge. We are out there every single day, Monday to Friday, and on weekends. And we do that because of the partners that we have. We do that because of the connections in the community that we've been able to build through a drop-in center that created a space that is free of stigma, that is open for individuals to be themselves in a way that is safe. And we invited partners to say, we can't do this on ourselves. None of us can do this on ourselves. Let's work together because we know what the solutions are and we can actually help make the solutions happen. And so for us, our guiding principle when building and creating partnerships is focused on addressing the social determinants of health and making sure that people have the circle of care that they need in a way that is accessible and safe for them at that time. And so we're thankful to all of the partners that are listed here. And I want to give 2 shout outs. There are many partners that are not listed here because there's only so much room in a slide. But I do want to give a shout out to the people who actually do the work, to the people that are there on the front line every single day. So to Emily, to Laura, to Michaela, to Jordy, Christy, and Jen, who are in outreach, in harm reduction, who are peer support workers. Also a shout out to Dr. Quinn Steingart, who's here, to Marjorie Knight, who is the chair of the board of directors at Thrive, to Jen Gordon, representing the region of Waterloo, who's one of our funders, and many organizations that I've seen from across the region of Waterloo, including Porchlight, including One Roof, people who every single day show up to say we're going to build a better community and we're going to do it together. So to everyone who's here in the room and who made it to Montreal, and for all of the work that you do, thank you.
All right, so putting it all together, why address housing and healthcare concurrently? I wanted to share an example of an individual we've been working with. He's been connected to our program since the beginning, and with Thrive and Sanguine even before that on the community van. This person has been living in encampments about 6 or 7 years. He uses crystal meth and attributes a large part of his use to fears of sleeping through the night out of concern for his belongings being stolen or he himself being harmed. When offered an option for transitional housing, this individual was not successful. He reported mood swings and emotional dysregulation that made the dorm-style housing very difficult for him. When back outside, our team connected with him and at his request, set up a mental health appointment with a nurse practitioner from a partnering agency. The NP went through his medication history and ended up prescribing a mood stabilizer or antipsychotic, which would help regulate his mood. One of the side effects, particularly in the first few weeks of taking this medication, is some drowsiness. And even at his starting dose, he reported he slept soundly for 2 days straight. I received a call when he woke up, and he was not in a position to take a medication that would make him sleep so deeply that he wouldn't wake up if someone came to his site. So he immediately stopped taking his meds. This is a classic example of the cycle that we find so many of our folks in, where his challenges in remaining housed might be mitigated with mental health or health treatment, but treatment feels inaccessible until he is somewhere safe. We continue to work with this individual through our model, working with alternative treatments and counseling options until appropriate housing becomes available. At this time, he is still outside, but we feel we're getting close. We hope.
Okay, so what does this look like in practice? Well, you're looking at it. A closely knit, multidisciplinary team that provides both healthcare and housing support to the community. Our work is rooted in harm reduction, compassion, and meeting people where they're at. Day-to-day activities can include everything from supporting clients at medical appointments, visiting encampments and shelters, completing wellness checks, providing wound care, following up on treatment plans, delivering supplies, and connecting individuals to housing or other essential services. No 2 days are the same, and the team adapts to the needs of the community and the people we serve.
And how does this method support long-term housing stability? By addressing health needs as proactively as possible, this model offers a foundation for stability for clients as they navigate their housing journey. Drawing from the Housing First model, housing is the foundation for good health. Complex medical needs, substance use disorders, and mental health challenges cannot be addressed effectively when survival is at the forefront. Furthermore, many housing opportunities are not accessible to those with complex needs, further perpetuating their homelessness. While we know that Housing First is not always an attainable option in our region's housing climate, we can start by putting some of these pieces together. The concurrent approach attempts to break this cycle by ensuring that services are accessible and utilized. When health is taken care of, we can address other barriers to housing. We can offer opportunities to build independence by tapering off intensity of support. We can help clients build more connections to agency resources and social supports, and recognize that housing is more than a roof over your head, but the resources that allow people to thrive. And that's what we got.
Amazing. Thank you so much, Emily, Laura, and Jose. We've got about 20 minutes for questions. We have more people than chairs because we have so much knowledge in the room, but I'll invite the other presenters back up on stage and we'll play musical chairs. We'll figure it out. And if folks have questions, there are, I believe, there's a mic. There's a mic over there, and there may be a mic that. Is there a mobile mic that we can run around, or I think if you got a question, head over to the microphone there, and you can pose it to a specific presenter or presentation, or the group. And please do use a microphone so we can make sure that the translation catches it, as well as any folks who are tuning in online. So I think we've got some questions coming. Here we go.
Can I go? Is this on?
Yeah.
First of all, thanks to everybody up there. This is an amazing way to kick off this conference, and to hear from folks that are on the front lines doing this work is always very motivating and very rewarding. So thank you for showing us the real value in getting together on the front lines to do this work. My question is mainly to Thunder Bay and St. John's. I'm pretty familiar with what's going on in the Waterloo region, but in your collective impact efforts to get funding for this work, how much do you include non-government sources? Do you look into the private sector, the rich folks that want to make a difference, the corporations? How much do you bring in those kinds of sources of funding?
Yeah, do you know anybody?
I was hoping you did.
We don't realize a lot of cash from people with deep pockets. They tend to be the good citizens of Thunder Bay who hate our living, breathing guts. But where we do see a lot of love is coming from other organizations. So, you get to that period of time in the year, fiscal year end, all the EDs grown with me now. And there's this little pocket here and this little pocket there. Or you might have a program that you launched or got funded only to find out that you're not going to be able to distribute it, right, in a timely manner. And so they'll reach back to us if it falls within any of the work we do, either the healthcare, the social services, the housing, the harm reduction stuff, and they'll give us money. So one year, Anishinaabe Nations gave us $10,000 and said, here, go buy backpacks and tents and those types of things. Nokiwin Tribal Council, they're looking at getting us some winter gear that we can give out to people who are in the encampments. So lots of different organizations that way. Norwet, the local community health center. I don't know how many times they've come to us and said, "Here's $5,000 in bus tickets," and we do a little happy dance. So and I feel like that didn't really happen until COVID. Because before that, it was like we were all kind of like these little misers. We had our own little bundle, and we just kind of kept it to ourselves. But there's been a lot more sharing and reciprocity since COVID, and it is a nice trend to see continue on. Sometimes we think we have a good reach, and we find out we don't. We just partner up and get it done. So yeah, nobody with deep pockets loving us, but if you ever meet them, give them my phone number.
It's kind of my call out to organizations like ours that are out here doing this work, that I think that's where we need to tap into. No fault to the municipalities that we work with. There's representatives from mine that are here that we work with great individuals, but governments do not have this figured out. They've proven that it's not in their best interest for whatever reason to fix the problems that are right in front of them. So we have to go beyond that, and I'm hoping we can all figure out ways of doing that. Thank you very much.
I just want to add that in Thunder Bay, nonprofit organizations manage reaching home funding, not government. And that makes a huge difference. And I know that's an anomaly in Canada. That's not usually the case. But if you can get it to where you have at least a nonprofit included, you'll see a world of difference happen in your community.
Hello, everyone. Since English is my third language, if I may not able to deliver the politically correct term, my apologies, because I'm going to touch a really sensitive issue here. I moved to this country like 10 years ago, being a refugee, born in a refugee camp, growing up in a boarding school. I can pretty much relate the struggles of the the Aboriginal people. And my question is not specific to one individual, but all throughout the organization, whoever can answer this. What I'm looking into is when we talk, because when I read about the Aboriginal peoples and all the issues, my understanding is they were kids at one time. They have a family, they have a friends. My question is, how would the reserves, I haven't seen any reserve yet, how would the reserve community support the people with indigenous people who are facing whatever the issues? How you get the support from the reserve in order to incorporate into community kind of healing? That's my question. I'm sorry if did you understand my question? Basically, I'm looking into the kind of the network structure the Aboriginal community is already there, supports the people who are facing the crisis on the street or homelessness. Thank you.
Thank you. I can try to speak to some of those points, I suppose, so from the Friendship Center. So first of all, I think something that's important to recognize, I think, is that the reserve system is a colonial system, right? So it's set up by the Canadian government and was set up to fail right from the start, right? So I think acknowledging that at the forefront. I think, so with the Friendship Center, I work at the Thunder Bay Indigenous Friendship Center, and we're an urban Indigenous service organization. So community members who are coming from, remote communities know that the Friendship Center is a service available, as a support for when they are in the city. And I'm not sure if this is the same across Canada. This is my experience in Thunder Bay, but we do have a number of tribal councils and other Indigenous communities who are providing service in the city for community members who have come from the north. And so I don't know if that's the same all across Canada, but that's sort of what we see in Thunder Bay.
My question is going back more into the community of the reserve.
Mm-hmm.
How does the community see this?
I see someone with a hand up. They might be better if they want to speak to that. Yeah.
Yeah, thank you.
My name is Michael Sadler, and I'm the Executive Director of the First Nations Housing and Infrastructure Council in British Columbia. And this is the thing that we're struggling with huge with regards to our First Nations people being homeless off reserve. ISK doesn't fund anything to do with homelessness. They've told us that, clear. We're negotiating a transfer arrangement with them, and they said, we don't want anything homelessness in your transfer arrangement. And I said, why? The reason our people are homeless and on the streets is because of you. Because of residential schools, because of the Indian Act, collective trauma. So and my purpose wasn't to get applause, but it frustrates the hell out of me. And so I'm saying, no, we are going to address homelessness. We are going to put it into our transfer arrangement. Our chiefs have told us we don't have resources, both human and fiscal, to be able to work off reserve. We have to rely on friendship centers and groups like yours to do that for us. We need to make more connection though between the two, because there's a lot of back and forth migration, as you know. So we need people to really rally and say, hey, ISK, you guys got to start funding this thing. And we have to piecemeal our funding together. That's ridiculous too. Every single year, all our organizations like yours are in survival mode, piecing together. We need a national strategy for homelessness. It's time to do that now. ISK needs to play a role and step up to the plate. And quite frankly, when I look in this room and that first gentleman, this guy here, he's right. I'm thinking about these are not the wrong people to be in the room. You're all bought in. You're all doing it. We need corporations, the rich people, the people who are going, what's wrong with these people? Why are they homeless? Well, if you don't have never experienced that, then you need to get involved, and that's Anyways, I thought I'd just kind of offer that.
Miigwech.
Love the collaborative approach to questions and answers.
Yeah, and maybe we should let people know who needs to be invited next year. I mean, we're all a captive audience, right? So I think that's important to advocate for who we want to get this information to.
Never follow the passionate Indigenous guy, because it's never going to work. My question is so I'm from Alberta. We have a provincial government that is less than helpful and is redirecting all harm reduction funding, community health funding to recovery. So our harm reduction agency got cut by 75%. Our sexual health clinic shut down. We still have some mobile outreach teams and stuff. So I'm just wondering kind of some suggestions on how to advocate in a way that, because we're just beginning to see what that impact is going to be. And again, so I'm from Red Deer. We have, I think we're at 60% of our pit count identified as Indigenous as well. We're surrounded by 6 nations, First Nations, and we have a huge Métis population. So yeah, just looking for some advice.
Thank you for the question. Growing up, my mom would tell me, if advice were good, it wouldn't be free. So take anything I say with a grain of salt, please. And it's actually tying back to the last comment. We have to recognize that we are working in colonial systems. We have to recognize the history and the realities of the lands and treaties that we're working on. Remember that we're treaty people. And so when we're talking about collaboration, when we're talking about harm reduction, when we're talking about governments or reaching out to corporate sponsors, we need to recognize where we're starting, right? And we need to recognize that we're all not starting in the same space, or we don't all hold the same privileges. To your question, there are a couple examples of doing work that moves away from how work has been done in the region that we come from, in the region of Waterloo, and they're actually in the back right now. So before you leave, connect with them. And I am looking at the folks that are going to be helping open the Winter Warming Center in Cambridge on Saturday, which is a first of its kind warming space. And literally the first time over the last 5 years that we've had a space for people that aren't welcome in shelters to not freeze to death outside. And then we also have the first 24-hour women's emergency shelter in the region of Waterloo. A community of about 560,000 people. By 2050, we're going to hit 1 million people. Just last year, we opened the first 24/7 women's emergency shelter. The answer to your question is, don't accept the crumbs. We're used to taking the $10,000, $20,000, $50,000 and saying this is going to be fine because it's better than nothing. There's something to be said about not biting the hand that feeds you, sure. But when you're talking about the hand being Premier Danielle Smith, that's a different conversation. When you're talking about Doug Ford, that's a different conversation, whether you like his ad or not. But when we look at the removal of harm reduction, we look at ways in which systems are being built to remove people from existing. And so that's why I started talking about how we're in a colonial system, because that colonial system was built to remove people from existing. When we remove harm reduction, we're doing the same thing. When we remove healthcare services, we're doing the same thing. So it is being able to be loud. But one thing I will say in terms of advice, find your people. Be with community, be with those that you can hug and cry and yell at if you need to go to a smash room, do that way. But being honest, like find your people so that you can be supported and healthy and whole, to then take the fight to the municipal government, to the provincial government, the federal government, whatever it looks like, and don't back down. It's hard, hence why find your people first, because if you do it by yourself, you're gonna get bored and you're gonna get tired out. And so bring everybody around you to the fight.
I just wanted to add something. I just wanted to add something else to that, is that we've been doing harm reduction, like the community and people who use substances, before we had funding, before we had these programs. So really just rallying with each other and the organizations, and like Jose said, being loud. But yeah, just remembering the people that have been doing this forever without the help, and yeah, hug your friends and yeah.
I think we've got time for one more question.
I just had a question on follow-up to the case study from the first presentation. I was just curious as to what type of housing they moved into and what you think made that successful compared to the previous placements.
It's in a private market apartment. He's living with his son. He wasn't transitional, that didn't work out. He didn't like the rules, didn't like away from his supports. No visitors allowed. He didn't want to be there. So he said, I'm going to go back to the street. Then he went into more of a supportive housing, and that didn't work out because of other guest management issues with the other tenant that was in the house, and he left that and went back on the street. Then we connected with him again, and he's housed now for over a year. So, yeah, that's one of many.
All right. Well, that seems like a positive note to end on. Also, don't bite the hand that feeds you, but do bite Danielle Smith. Great. Thank you so much, everyone. Thank you to the amazing speakers. Really great hearing from folks who are, really on the front lines doing this important work. Have a great conference, folks. Have a great lunch. It is in room 517 right now. And if you have questions, speakers are here. You can find them on the app or maybe grab lunch with them. Take care.